Thank you, InFocus, for inviting us to speak at such an important forum today. Kylie and I would like to use this opportunity to discuss the role of B-lines in lung point-of-care ultrasound. We have no significant disclosures to make. I'm a respiratory physician, and Kylie is an emergency physician both of us practicing in Australia. We do get together for great conversation and a drink when we teach at the beautiful Gold Coast in Australia.
We want to talk about a common problem when B-lines let us down, but unfortunately there won't be enough time to discuss the different settings, other than to say every report must contain detailed instructions on what settings were used. Neither will we have time to go into the fascinating research on B3 and B7 lines, or elastography, or shear waves, or the iceberg protocol. We'll just have to stick to basics, I'm sorry. Now, as an emergency physician, I see breathless folks every day. And when I hear that someone has fibrosing lung disease, this is the chest x-ray I'm expecting to see. When I put on the ultrasound, I expect to see B-lines, fairly symmetrical, fairly bilateral, increasing in density posterobasally. When I look closely at the pleura, I expect to see a fragmented or moth-eaten pleural edge. And if I can, I like to look at the heart to make sure there's no glaringly obvious left heart failure and whether there might be any right heart strain. But unfortunately, not all cases are as simple as this. And before we go any further, I'd like to ask Ben to start explaining to you the complex nomenclature around respiratory medicine.
To help us in understanding what B-lines means in lung point-of-care ultrasound, let's actually look back at some of these consensus documents published by the American Thoracic Society and the European Respiratory Societies. Back in 2002, it set up this classification of different patterns of interstitial pneumonias. Sensibly, it's always ranked from the most common to the least common. It's important to note that interstitial lung diseases, or ILDs, encompasses really a large group of more than 200 parenchymal pulmonary disorders, of which really the majority of them are classified as rare. This classic document on ILD is really split into 4 major subgroups, in terms of lung causes, the IIPs, the granulomatous lung diseases, and the unique rare entities. And as you can see in this diagram here, there's a third proposal to classify the idiopathic interstitial pneumonias, or the IIPs, to different pathological entities, in which the most common of all is the idiopathic pulmonary fibrosis, as well as other more rarer entities. And in recent times, there's a further importance in the role of a multidisciplinary team approach to classifying different types of ILDs. Together with improvement in technology, and especially in the role of HRCT, or high-resolution CT scan, clinical and radiological findings often can help us to come into a better understanding of potential causes in the IIP group. So this is now broken into either major or rarer forms, or in those where there is inadequate clinical, radiological, pathological data or discordance between those findings into the unclassifiable IIPs.
Thanks, Ben. We'll need those terms later. If I was to summarize very briefly, I'd say that the research has been done either by rheumatologists investigating connective tissue diseases and the respiratory physicians who've looked at the idiopathic pneumonias, but they do tend to borrow each other's nomenclature. Here is my problem case, a critically dyspneic patient who'd had recent chemo and radiotherapy. In this lung ultrasound, I was really expecting to see some B-lines, but there was just a fairly sharp pleural line contour anterior to the heart. Laterally was not much different. In fact, here are the only B-lines I found in this patient, off to the right anterior. Even the heart looked good, not a hint of right heart strain. So I was really perplexed to see a chest x-ray like this. Normally my lung ultrasound is more sensitive than the chest x-ray. And I was mortified to see this CT. It set me thinking, how on earth did I miss this? What went wrong with my technique and how do I avoid this in the future? It turns out that our respiratory physicians have been pretty wary about B-lines for quite a long while. And I'm going to ask Ben to briefly summarise some of the literature on B-lines and pleural irregularity in interstitial lung disease.
To try to help us understand what are the typical findings that can be found in IODs under lung ultrasound, many of our fellow colleagues have researched the role of B-lines and pleural abnormalities under ultrasound imaging for many years. But this is a field of rare diseases, many of the studies have small sample sizes, with the largest being around 200 to 300 or so patients. And most of this research is reported in terms of correlations and followed by sensitivity and specificity, which of course are very dependent on pretest probability. It is also important to understand that respiratory physicians, emergency physicians, and other subspecialists may ask very different questions in terms of either for diagnosis or for prognostication, or is it for monitoring over time, or whether the treatment outcomes. And this is where the field then diverges, and the importance for us to understand the literature differences behind all this.
When you read any paper, ask yourself which conditions are included, and more importantly, which conditions have been excluded before the study starts.
And I've said before, B-lines have been studied for many years. This is, in fact, a reverberation artifact. And many of the papers looking at B-lines in chronic lung diseases, typically in the IODs, are really on systemic sclerosis. B-lines are visible when the lung parenchyma air content is partially decreased, and or the interstitial space is volumetrically expanded, such as that in pulmonary edema or IODs. So it is important to underline that B-lines cannot be clearly correlated to a specific anatomical structure, but they are correlated to the changes in the physical properties of the lung. So if you're asking the question why systemic sclerosis are most studied, it's because this is the disease most often associated with ILD, with up to 90% of patients exhibiting evidence of ILD on HRCT, and therefore it is the most studied and used for validation. And if you look at some of these recent systemic review multivariate analysis, you can see sensitivity is generally better than specificity. So it is a relatively fair rule-out test. But the area under the curve decreases as soon as you widen the inclusions beyond systemic sclerosis to include other types of connective tissue diseases.
Pleural line irregularity has also been studied, and it's shown to be even more sensitive, but even less specific than B-lines. With our high-resolution linear probes, we can get a beautiful view of the pleura this day and age. And I think the recent COVID pandemic is going to seriously confound the diagnostic test characteristics for pleural line irregularity.
That's one of the biggest, most recent studies that did combine B-lines with pleural irregularity. And what it does is divided the individual sign-ups and correlate them with HRCT finding, which is still considered to be gold standard image modality. But you can see the results actually looking at the correlation starts dropping dependent on the pattern that is seen. Reticular pattern having the highest correlation, the efficiency, and then start dropping as we look at the other types of finding that may be seen. And it's important then to recognize that irregularities of the pleural line do not correspond to alteration of the anatomical pleura that is not involved in the disease. Rather, this sonographic image of an irregular pleural line is the effect of the subpleural interstitial alterations, which with decreases of aeration in the lung periphery. So although we may observe a perfectly regular pleural line with multiple B-line in the early phase of the disease, the irregularity of the pleural line is always and for definition accompanied by B-lines. It is of this reason that the morphological description of the sonographic image of the pleural line may be redundant information once you make the diagnosis of an ILD. So B-line then remain the main critical signs to look to diagnose and used to prognosticate the ILD.
I think what frightened me most about Buddha's paper is how many of the HRCT findings were not correlated with superficial lung ultrasound findings. Particularly, notice the last one, ground glass opacity. Ben, just how important is ground glass opacity anyway?
And in terms of ground glass opacity, this is a radiological finding in CT scan consisting of a hazy opacity that does not obscure the underlying bronchial structure or pulmonary vessels. It is considered to be a manifestation of a wide variety of clinical features, including both malignant and benign conditions. And you can see down here there are lots of different conditions across the spectrum. But GGO is considered to be the hallmark of an NSIP pattern, a halfway ill-defined condition that can morph into just about anything if not treated early. And NSIP, by definition, has more ground glass opacity than reticular change, and is also known for being a more central process compared with the more peripheral reticular patterns that are the hallmark of the usual interstitial pneumonia or UIP pattern. So if we now look again at the ATS-ERS classification of the IIP patterns, and then we can see which one have the characteristics that we can see on lung ultrasounds. So in this slide, we have ranked the IIP patterns from most common to the least, and we pair it with the CT description to the right. But then we gray out the quality that are poorly demonstrated in the lung ultrasound, such as the GGOs. So you can see it doesn't really leave us much that we can see under lung ultrasound in terms of CT pattern distribution. So the only pattern that we can reliably expect to see is the UIP pattern, which is the most common pattern that is seen in systemic sclerosis ILD, which is why majority of the paper is reported with this condition. So hence what we would like to say is that lung ultrasound can undergo the occasional rare but very debilitating interstitial pneumonia subtypes. And to summarize,
Yes, to summarize, respiratory physicians compared to emergency physicians will scan many more zones. They will focus on the posterior basal section because that has the highest yield for the interstitial lung diseases. Their pre-test probability of illness is very different from my walk-in patients in the emergency department. And it could be that pleural line irregularity is now going to be too sensitive for useful work. Remember that in established chronic interstitial lung disease, it's the reticular patterns, the systemic sclerosis, that will give you the best, most reliable B lines.
And equally, it is very important for us to understand the limitation of lung ultrasound in ILDs, where B lines can have various etiology and the role of pro-abnormality needing further studies, and really study B line as a diagnostic tool with minimal data on chronic causes or response to treatment, and lack population data on normality. So in summary, lung ultrasound can assist but not replace HRCT. If the lung ultrasound is empty but HRCT is busy, suspect an active evolving inflammation process. Whereas if the lung ultrasound is empty but the chest wall is full, then look for centrilobular lesions and get that CT scan urgently.
Thanks, Ben. It's been great to have a reason to dive deeply into the literature. I hope we've managed to give a useful summary for you. And thank you very much to InFocus for this great opportunity for Ben and myself to give our perspective.